One trick with the FluoroSafe, you calculate 1 second on top, you put your feet on the pedal, in 1 second it's gonna show up. So you wait 1 second, and before it shows up, you take the feet out of the pedal, and it will show up for the FluoroSafe, which is the best way now to save some radiation. Well, again, I want to thank Dr. Sharma for inviting me here. Let's see if my slides I loaded up. Yep. So we're going to discuss details on atherosclerosis. I'm going to start with one question, okay? And this is just fun, okay, guys? Don't get stressed out. This is just to have a good time here. So according to the American Heart Association, which of the following lesions are considered early plaques? The fatty streak, the atheroma, the preatheroma, A and C, or all of the above? A and C, very good. So we have the early plaques are the non-specific intimal thickening, which is not really an atherosclerotic plaque, but is prone to develop athero. Why does it happen? Because of the Laplace law. The Laplace law, remember, the wall tension is related to the thickness. So you reduce wall tension if you increase thickness. That's why the vein grafts develop neointima, because they don't have tunica media. The tunica media of the vein is very, very bad. So they have to counteract the wall stress. Thickening, that's neointima, that's normal for the vein grafts. And you can have, when you're born, the intima is a virtual space between the endothelium and the internal elastic lamina. So virtual space when we're born. So there's no really tunica intima. We develop that because of the Laplace law. Then, if you have oxidized LDL, you get the macrophages in, and then you have the fatty streak, which is the type 2 lesion, very important lesion. We're going to talk a lot about it. And then the type 3 is when the macrophages die and the fatty becomes extracellular. Here the fat is intracellular. Here it becomes extracellular. But there's no necrotic core. It just pools of lipid, extracellular lipid. Then we have the necrotic core. The type 4 is the classic atheroma. The fibroatheroma is a response of collagen that obstructs the lumen, could be 20, 30%. And then finally, we have the complex plaque. So this is the non-specific intimal thickening. We have the proteoglycans there, PGL. They're like goalkeepers for the oxidized LDL. You have few cells, but really it's a virtual space, as I said, or very, very thin layer. Then we have trouble, because we have the fatty streak. And you can see it's also called the giant cells. And you can see them on light microscopy with the trichrome stain or with the H&E. It's very easy because it's like 40, 50 microns in diameter. So they're big cells full of lipid, macrophages full of lipid. They cannot make the actual process to give this free cholesterol to the ApoA1, which is the pre-HDL, and they die. And they could die for two reasons. One, for pure hypoxia, that we'll see, or for apoptosis. I think it's more pure hypoxia, to be honest, but apoptosis is a little bit fancier, so people use the apoptosis hypothesis. And that's what I bring this slide here. The forward pathway of cholesterol. Cholesterol is synthesized and produced in the liver. It goes as VLDL or LDL, and then the macrophages take over the LDL cholesterol. The cholesterol esters are converted into free cholesterol. Okay? Very important. Free cholesterol is the one that is given to the ApoA1, not cholesterol esters or crystals that you see on the microscope, but are the free cholesterol that through the cassettes, the ABCA1 cassette, or the ABCG1 cassette, or the SRBI, that's how the macrophage give back the free cholesterol to the ApoA1, pre-beta HDL, and then the big HDL that comes back and take care of the reverse cholesterol transport. So that's a brief review, but important for you to take home message. Reverse cholesterol, pre-beta HDL, or HDL, then the big HDL, which is the alpha HDL, and then back into the liver. So remember, what do you see here? A little pool. Extracellular lipid. The pool, where is it located? It's not at the lumen. There are few, but not really. The majority is in the intimo-medial junction. Why? Because that's where the hypoxia is. The pressure of oxygen in this intimo-medial junction in plaques is about 20, 18, 22, incompatible to aerobic cells to survive. So that's why the macrophage died in the intimo-medial junction, and that's where the necrotic core starts. So question, easy question. Which is wrong here? The type 1 lesion is a protoglycan-rich and prone to develop athero. The type 2 is characterized by foam cell infiltration and may regress. The type 3 lesion is characterized by pools of intracellular lipid and collagen. And finally, early lesions are flat, always asymptomatic, and do not obstruct the lumen. Which is the wrong statement? I need some help. Jump, Carlos. C? C is the wrong statement. Yeah, it's extracellular lipid. Very good. Now we go to the type 4, the atheroma. You're more familiar with this image. You see, the lipids, the lipid pools are now coalescent, and they develop this necrotic core that is composed by cholesterol crystals, cholesterol esters, protoglycans, water, and necrotic debris, specifically necrotic debris of one cell, which is the most predominant cell in the necrotic core. If you stain for the membrane of a cell, which is the one that would be more abundant in the necrotic core? Wrong. But I'm going to tell you later which is the one. Okay? Okay, now you advance, you get neovascularization, you get intraplaque hemorrhage, thin calf fibroateroma, and calcification. You have the microcalcification or the coarse dense calcification. This cannot be seen by CT angios. This will be seen by CT angios. And calcification is important because the history goes that Dr. Monkeberg, a pathologist in the Cook County in LA, was trying to reproduce or find the disease, the virtual disease in the actually, Blackenhorn was trying to find Monkeberg disease in the coronary arteries, and he didn't find. Monkeberg disease is in the media. So calcification of the media, Monkeberg disease is in the lower extremities. He was looking for that in the heart. He didn't find it. All the calcium was in the intima. So calcification means disease. It's pathognomonic of atherosclerosis. There's no way you can have calcification in the coronary arteries if there's no disease there. And you have to be familiar with the metabolism of calcium, specifically with this disease called dystrophic calcification. Dystrophic calcification means calcification outside the bones. It could be in any gland or in any organ. That's called dystrophic calcification. And it happens because of distortion of the homeostasis of calcium. There are some cells that are in charge of the destruction of calcium or the bone, osteoclast, specifically the non-collagenous proteins, okay? Osteonectin, MMP1, PI1. And there are cells that are responsible for the formation of bone, also non-collagenous proteins, osteopontin, osteoprotegrin, the MCP, metric glutamic acid-derived proteins, and most importantly, the PTH resorption. That's why you have in patients with renal failure and dialysis, you have so much dystrophic calcification because PTH can go to the roof, can go to 1,000. PTH should not be that high, so that's what's happening. And you must be also familiar with the metabolism of these non-collagenous proteins. How do they act? Where are they expressed? And what are the mechanisms? And you are very familiar with that. Bone mineralization, PI1, MMPs, and it's expressed in macrophages, platelets, and fibroblasts. These non-collagenous proteins responsible for coronary calcification are expressed in the cells that are the main actors of atherosclerosis. If you correlate the amount of calcium and the plaque area, you have the square root of plaque area and the square root of calcium, you have a relationship that is important. But if you correlate it with the lumen, there's absolute no correlation. So calcification is associated with plaque area. The larger the plaques, the more calcium you have, but it's not associated with obstruction of the lumen. And why? Because it's an independent predictor of atrophy of the tunica media. Calcification is an independent predictor of atrophy of the tunica media, so there is remodeling. Of course, at the end, with extreme calcification, you will have obstruction, and that's the whole story about calcium scores and obstruction atherosclerosis is only 50% predictor. But the key here is for the exam, you have to know calcium is associated with plaque area, but it's not associated with stenosis. So using Dr. Sharma's slide here, how you classify coronary calcification in the coronary arteries by fluoroscopy. We're talking fluoroscopy before you give the dye. None, mild, moderate, you do dense radiopacities during the cardiac cycle before the contrast injection. But most importantly, if you see the tram track that we were discussing this morning in CATH conference with Rahul, the tram track, you see it, you don't need to do IVUS or OCT, you know severe calcium, and you need to debulk. Okay? This is the incidence of severe calcification is about a third. So a third of the patients with obstructive disease will have severe calcification. So that's why you must develop expertise in the technology to deal with these plaques. This slide also shows the severe calcification. But this slide is probably one of the most important ones that you can take home message. What does this slide say? Severe calcification can give you 20% MACE at 1 year. Unbelievable. The normal MACE for PCI is about 4 to 6%. As target vessel failure is about 9%. Of those, about 4 to 6% need reintervention. We're talking here 5 times more. 5 times more just because of severe calcium. And look at death, 6% at 1 year. You imagine 6% death at 1 year in severe calcification. This is all comers. This is data from many patients, 6,800 patients. And then you have the advanced plaques, the fibrotic plaque, and the complex plaque, which is the ruptured plaque with thrombosis, or the eroded plaque. Difference between the two in definition: in ruptured plaque, the necrotic core is in direct contact with the lumen. In plaque erosion, there is no direct contact between the necrotic core and the lumen. In other words, there is no plaque rupture. There is plaque erosion. And finally, you have intraplaque hemorrhage, which is the type 3 of the complex plaques, the number 3 of the complex plaques. Multiple healing, multiple plaque rupture will give you collagen type 3 with healing, then you create another plaque on top, and multiple healing will give you chronic stable angina. Actually, patients with obstructions over 80%, the average number of plaques, one on top of the other, is about 4. So that's data from Michael Davis and Renu Virmani that showed that the healed plaque is responsible for chronic stable angina. Question number 2. Which of these is false? Which statement is false? Dystrophic calcification is mediated by non-collagenous protein expressed in macrophages. Severe calcification is associated with increased mortality after PCI. Coronary calcification is associated with the severity of coronary stenosis. You make me happy. You're paying attention, huh? Good job. Okay, another question. Which is wrong? Which statement is wrong? The tunica media dries oxygen from the lumen by diffusion. Hypoxia evolves when the distance from the lumen to the tunica media is greater than 500 microns, 0.5 millimeter. The molecular process of angiogenesis is driven by hypoxic inducible factor 1 alpha. Neovessels are characterized by structural tunica media and pericytes. And neovessels evolve from adventitia vasa vasorum, but progenitor cells may also contribute. This is not an easy question, huh? Well, it's important for you to know who wants to take a chance here. Which is the wrong statement? This is the wrong statement. And it is important Because if the neovessels will have tunica media and perisize, there will not be intraplaque hemorrhage. The problem with the angiogenesis in atherosclerosis is that these little microchannels have no tunica media, and therefore they leak. This microendothelium is subject to the pH of the necrotic core, which is about 2. And all these acidic components destroy the microvessels, and then the red blood cells get out. And that's a problem. That is what is called intraplaque hemorrhage. But before we get into that, diffusion is the way the tunica media gets oxygen, and it has to be less than 500 microns. So the tunica media is fine with that. The tunica media we divide in the inner tunica media and the outer tunica media. The outer tunica media is fed by the vasa vasorum. The inner tunica media is fed by diffusion. If you develop a plaque more than 500 microns, there's no way you can get oxygen here. So hypoxia will kill the macrophages in the intimo-medial junction, the fat will get extracellular, lipid pools, necrotic core. Progression to thin fibroatheroma and plaque rupture. We already talked about this. This is the vasa vasorum, okay? These are the vasa vasorum. In the adventitia, these are very good established tunica media vessels that originates from the bifurcation of the arteries. The bifurcation, those goes in the back, and they feed the outer tunica media. You can see it under the microscope, very nice vessels, like when you see pulmonary hypertension, the microvessels in the lungs. They penetrate. It's like septal perforators, or the type 1 and the type 2, the ones that penetrate into the inner media and into the plaque are the ones that are trying to provide oxygen to those cells that are asking for oxygen. If you look for hypoxia with a specific marker, where is this hypoxia marker NITP staining? The intimo-medial junction. You see that? That's where the hypoxia is. They are usually from the adventitia, but there is about 5% of them that can originate from the lumen. But the great majority of these neovessels originate from the adventitia. And you can identify them using immunohistochemistry. If you give, let's say, a violet color to the CD34, you can see, or in blue, you can identify them and count them. They are predominantly seen dramatically increased in rupture plaques. See? They are dramatically increased when compared to the early plaques, non-specific intimal thickening, the fatty streak, the preatheroma, the atheroma, the fibroatheroma, the calcific plaque, the fibrotic plaque, or the rupture plaque. So if you do a linear regression analysis or just a multivariate, you will have the type C plaque as an independent predictor for neovascularization. But why is that? These plaques are usually twice the size of any other plaque in the coronary arteries. The size of the rupture plaques are humongous. In our studies, the average was 14 square millimeters in the rupture plaques in the aorta compared to 7 to 8 in the fibrotic and in the calcific plaques. So they grow so much, usually eccentric, to a point that they cannot grow no more, and they just have to rupture. And the process in the activity, the metabolic activity inside the plaque that is growing and growing, will lead to plaque rupture through the fibroscap. And if you compare the amount of neovessels with high-risk plaques, these are thin cap fibroatheromas and these are rupture plaques, they're very similar. It's total neovessel. There's almost no difference between the high-risk plaque and the rupture plaque. Interestingly enough, the fibrocalcific plaque, which are actually a large plaque too, it was 10 square, has very little neovessels. And the question is why? Let's talk about it. So, which is the wrong statement here? The type 4 lesion have a lipid core, but still do not have a well-formed fibrous cap. Thin cap fibroatheroma is characterized for cap thickness less than 65 microns, macrophages, and a largely lipid core. Extravasation of red blood cells within plaques increase lipid core expansion. And plaque rupture is most frequently symptomatic, leading to acute coronary events. Which one you think is the right answer here? which is wrong, is this one, because the extravasation of red blood cells will give you lipid core expansion. Why is that? I'll tell you why. Just move on a little faster. The magnitude of intraplaque hemorrhage in human coronary atheroma is tremendous. If you stain a coronary plaque with glycophorin A, which is a marker for the membrane of the red blood cell, and you quantify by computerized planimetry the amount of necrotic core that is stained by this antibody, and then you compare to the actual size of the necrotic core is almost equal, suggesting that by far the most important cell or remnant of cells, because we're talking about membrane here, is not the macrophage. The macrophage is probably 10% of the necrotic core. Here is the red blood cell. That is the relevance of intraplaque hemorrhage. And it is important for you to understand that the red blood cell membrane has 40% more cholesterol than any other membrane, any other cell membrane in the body. Of course, these red cells die, the membrane will increase lipid core, and the extracorpuscular hemoglobin, which is not designed to be outside the corpuscular, outside the red blood cell, will generate a lot of trouble. LDL oxidation, macrophage activation, inactivation of nitric oxide, MMP, smooth muscle cell proliferation, and apoptosis. Question: which is the wrong statement here? Coronary calcification is a predictor for future coronary events. Coronary calcification always reflects advanced disease by histologic criteria. Plaque erosion is more frequently seen in smokers. Chronic stable angina lesions are frequently healed ruptured plaques. And plaque rupture more frequently occurs at the center of the fibrous cap. Which is the wrong statement? Very good. You're right. Where does it more frequently occurs? At the shoulder. What is the difference? 58% at the shoulder, 42% at the center. It's not like everything rupture at the shoulder. Usually at the center is exercise-induced plaque rupture, like people that died during shoveling the snow. That people actually in autopsies have shown rupture plaque at the center. Another question: which is the wrong statement? Angiogenesis is responsible for intraplaque hemorrhage. Neovessel density is increased in large calcific plaques. Collagen type 3 is responsible for healing rupture plaques. High-risk lipid-rich plaques can have as much neovessels as rupture plaques. Wrong statement? Collagen type 3 is responsible for healing. That's correct. Type 3 is risk stenosis. That's collagen type 3 is risk stenosis and is also the healing of the rupture plaques. But the neovessel density in calcific plaques are increased or decreased? You guys remember? I'll show you the slide. See, in calcific plaques, fibrocalcific plaques, neovessels are very, very few, much lower than the high risk of the rupture plaque. So that's the wrong statement, is that calcific plaque has a lot of neovessels. That's wrong. The calcific plaque has very little neovessels. Okay, when atheros starts in uterus. Okay, atherosclerosis starts when you start life, before you're born. Why? The work of Carlo Napoli at Mayo Clinic, doing autopsies in fetuses and stillbirth, showed that in pregnancy-induced hypercholesterolemia and established hypercholesterolemia in mothers will induce atherosclerosis in babies before they're born. But the disease can be asymptomatic for many, many, many years. You can go up to very advanced histological disease with no symptoms. Only when you have an event, either chronic stable angina or an acute coronary syndrome, the disease is symptomatic and it can evolve into regression or total occlusion. Most importantly, when people did angiograms in patients and review angiograms between 2 years and 6 months before the STEMI, patients came, had a stent in the LAD, and the proximal RCA had a 20%, 50% lesion. Then the patient come back with a STEMI in the RCA. Let's go back. The great majority of those plaques were less than 50%, okay? Actually, 86% were less than 70%. Only 14% of plaques during STEMI, when you do the angiogram before, were actually obstructive plaques. Very interesting and old observation. So let's talk about that, which is the wrong statement here. Non-obstructive lesions are the most frequent cause of acute MI. Obstructive lesions can evolve into complete occlusion silently. The individual risk for plaque progression to complete occlusion is higher in obstructive lesions. And atherosclerosis starts in childhood and can be seen in the second decade of life. Who wants to bet here? So let's go individually. Non-obstructive lesions are the most frequent cause of acute MI. I just showed you that, huh? Obstructive lesions can evolve into complete occlusion silently. Of course, you can have RCA occlusions, you're cathing somebody. Yeah. Now, the individual risk for plaque progression to complete occlusion is higher in obstructive lesions. The individual risk. We're not talking here about patients. And for that, you have the prospect trial. The individual risk of plaques progression is higher in obstructive than in non-obstructive disease. Let's go to that. See, this is the individual risk of progression to a complete occlusion at 5 years. Severe lesions, 24%. That's what we do. We treat severe lesions. We don't treat non-obstructive lesions because their individual risk for acute occlusion are much lower. See, less than 50% lesions, 2-3%. Let's finish my presentation with this question. All of the following statements are true except non-obstructive lesions are the most frequent cause of acute MI. Okay, so atherosclerosis doesn't start in childhood. Atherosclerosis starts in utero. Okay, it's a difference. Another question. Non-obstructive high-risk plaques analyzed by IVUS virtual histology are characterized by thin calf fibril, lumen area less than 4 millimeters square, plaque burden more than 70. All of the above? All of the above. That's the prospect trial. Let's talk about it. These are the 3 independent predictors, and we have Roxana here. She was a co-investigator of that trial. Thin calf fibroateroma, minimal less than 4, and plaque burden more than 70. Okay, let's finish this. Which of the following statements is true regarding non-obstructive thin calf fibroateroma with lumen area less than 4 and plaque burden more than 70 at 3-year follow-up? The incidence is about 5%. They analyzed 2,600 plaques by IVUS. And they followed these patients for 3.5 years. And they identified these super high-risk plaques in only 5% of them. But the event rate was 15 to 20%. This is it. See, if you have the 3 major criteria for thin calf fibroateroma with plaque burden greater than 70 and MLA less than 4, you have an event rate of 18%, 17%. But only 4.6% of those plaques. So they are not ubiquitous everywhere in the arteries. They're difficult to find. Out of 20, only 1. But that one can give you 18%. So this is the question here. Future MACE events or DES, after DES, in ACS are mostly related to culprit lesion previously stented. That will be wrist stenosis. Complications of that. Non-obstructive plaques left alone at the time of DES. A and C. A and C. So which of the 2 are more frequently associated with events after PCI? The culprit lesion previously stented or non-obstructive plaques left alone? Which of the 2? They're equally. Culprit plaque-related events for wrist stenosis, dissection, whatever you want to call it, or progression of disease from non-obstructive plaques. I'm going to stop here, and I'm going to open this for questions.